is Robin Dixon, and I am a doctoral candidate at Alliant International University. And today my presentation is going to be on schizophrenia, creating public policies towards a better quality of life. In this presentation, we're going to discuss the Diagnostic Statistical Manual, TR5, which in short, DSM-5, criteria for schizophrenia, the implications for caretakers and stakeholders, potential policy and funding strategies, as well as why this is important. What's the clinical significance? DSM-5, schizophrenia requires the presence of at least 2 core symptoms during a 1-month active phase, with at least one being delusions, which can be grandiose, paranoid, or reference type, hallucinations, which can be auditory, tactile, or olfactory type, or disorganized speech, which is commonly known as word salad. Additionally, qualifying symptoms include grossly disorganized or catatonic behaviors, and they often present with negative symptoms, such as diminished emotional expressions and/or avolition. Importantly, the diagnosis is not based solely on symptom presence. There must be marked functional decline in occupational, relational, or service care domains. These disturbances must persist for at least 6 months and encompass both the active and residual phases. Diagnostic exclusion criteria are equally important. Clinicians must rule out schizoaffective disorder, mood disorders with psychotic features, substance-induced psychosis, and other medical etiologies. The DSM-5 also specifies that when autism spectrum disorder is present, prominent delusions or hallucinations must be sustained for at least 1 month before schizophrenia can be diagnosed. Therefore, it's important to recognize that these criteria embed many policy implications. Schizophrenia is conceptualized as a chronic, functionally impairing disorder requiring sustained multi-system intervention, not simply episodic crisis management alone. And that today is where we are failing in our public policies. When schizophrenia and its treatment are widely accepted, stigma tends to decrease and help seeking increases, especially early in illness. Now, this matters because delayed treatment is associated with worse functional outcomes. For individuals, acceptance can translate into access to antipsychotic medication, psychotherapy, supported employment or education, and even coordinated care. But also brings risks like labeling and discrimination if accommodations and protections don't follow. Families often carry large caregiving burdens. Acceptance supports family psychoeducation, respite care, and clearer pathways to crisis help. Regarding educators and employers, they benefit from clearer accommodation frameworks, flexible scheduling, reduced cognitive load, and support during system exacerbations. At the system level, acceptance justifies federal spending on evidence-based services, not only hospital beds. The funds need to be shifted towards community clinics, early psychosis programs, and housing supports and crisis symptoms. However, that is not currently the case. A central mitigation strategy is coordinated specialty care for first episode psychosis. CSC integrates medication management, psychotherapy, supported employment and education, family services, and case management, all within a unified model. This is delivered frequently through certified community behavioral health clinics, and it addresses both symptom stabilization and functional restoration. The rationale is evidence-informed. Earlier treatment reduces relapse frequency, improves employment outcomes, and decreases long-term disability. When integrated with 988 crisis symptoms and mobile crisis teams, CSC creates a continuum from acute stabilization to sustained recovery support. Funding-wise, States breed SAMHSA's block grants, Medicaid reimbursement structures, and crisis infrastructure funding. This policy's strength lies in requiring dedicated allocation rather than discretionary spending. So why does this help? The earlier treatment and the more support for both the individual with schizophrenia and their caregiver is going to lower the downstream of emergency room use, hospitalizations, homelessness, and again, contact with the criminal justice system. I believe recent advances are beneficial, especially the emphasis on parity enforcement, early psychosis care, and crisis access. But the benefits are uneven. Parity rules can reduce administrative barriers, yet enforcement and insurer compliance remains the bottleneck. 988 improves access, but without funded follow-up services, callers can still cycle back into crisis. And CSC expansions are promising because they operationalize the idea that schizophrenia care is recovery-oriented and community-based, consistent with clinical guidance like the APA schizophrenia guideline. My bottom line opinion, policy has moved in the right direction, but effectiveness depends on local capacity, workforce, housing, and Medicaid payments. That's the only way to sustain funding beyond time-limited